Good morning, friends. Welcome back to pediatric classes. Today, we are going to discuss about recurrent pneumonia. How can we approach the case? So, I'm going to share my screen now. If you have not subscribed to my channel, kindly do subscribe and support our initiative. So, what are we actually going to discuss in this session? We will be discussing about the definition of recurrent pneumonia, what are the types, what is the etiology, what are the pointers we get in history and examination, and what are the investigations. So what exactly is recurrent pneumonia? If the recurrent pneumonia is defined as a pneumonia with two episodes, at least 2 episodes of pneumonia in 1 year, or 3 episodes ever with radiographic clearing of densities between the episodes. The exact incidence is unclear. One of the studies which we said was around 7.7 to 9% of children with community acquired pneumonia is found to have a recurrent pneumonia. There's another important terminology here that is called as chronic or a persistent pneumonia. We need to differentiate between a recurrent pneumonia and a chronic pneumonia. So chronic pneumonia means it is an illness with persistence of symptoms and radiological changes for 6 weeks or more despite the treatment. Chronic pneumonias are usually caused by slow-growing organisms such as fungi or mycobacteria. Now, inappropriate or incomplete treatment is considered as the most common risk or reason for a recurrent pneumonia. Please note here, how can exactly we differentiate between a chronic and a recurrent pneumonia? We need to have a radiological clearance of densities in between the episodes. So many times we don't do an X-ray once there is a like clinical response. So that is why there may be an overlap of cases actually here. So if we can actually document a exact clearing of the densities after a pneumonic, then again the child is tending to have another pneumonia, then only we can take it as a recurrent pneumonia. So that is one thing. Okay, now what are the risk factors of recurrent pneumonia? The most general risk factors will be prematurity or bronchopulmonary dysplasias, atopy, tobacco smoke exposure, overcrowding, indoor and outdoor pollutions, etc. So there are two types of recurrent pneumonia. One is recurrent pneumonia, which is affecting the same lobe again and again and again. Another thing is recurrent pneumonia in different lobes or it affecting multiple lobes. So now first let us see what are the causes of recurrent pneumonia in the same lobe or segment. So there is a localized disease. Can be because of 3 pathologies. It can either be because of narrowed airways, or it can be because of congenital lung lesions like a benign lung cyst, or an emphysema, or a sequestrated lobe. We have discussed in detail about the congenital lung malformations in my previous video. So if you have not watched that video, you can go back and refer back to that video. So another thing is there is a focal bronchiectasis. Child tends to have a recurrent pneumonia in the same area. So what exactly is what do you mean by when we say a narrowed airways? So narrowed airways means one is extrinsic causes. What are the extrinsic causes? Extrinsic means that in that airways actually something is pressing in from outside. It may be a lymph node, it may be a neoplasm, or it may be a vascular ring. Or is there any problem with the bronchial valve? For example, when there is a ventilation, all this is happening when the wall is tending to collapse. So when there is a bronchomalacia, or when there is a laryngeal web, or there is a stricture, there's a problem with the bronchial wall. And what is endobronchial? Endobronchial is inside the bronchus. I mean, most common reason of one of the recurrent pneumonia is foreign body or a tuberculosis or neoplasm. So these are the general etiologies. This have got this image from a article which published in 2015. I have put the reference link in the end of the video. So it's a very good, simple article. That's why I have referred to so many articles, but this is one image which I got, and I acknowledge the author for the same. Now, recurrent pneumonia is affecting multiple lobes. So, multiple lobes that is getting affected. So, most common thing which you should suspect is some immune disorders. It may be a systemic immune disorders like a primary immunodeficiency or an acquired immunodeficiency or some local immune disorders. So, genetic disorders like cystic fibrosis or ciliary dyskinesis. Neuromuscular disorders, which can include both central and peripheral, can affect the lobes. An airway abnormality is like I told focal bronchiectasis is a cause of recurrent pneumonia in the same lobe. But if there is a generalized bronchiectasis or a bronchomalacia, it can affect multiple lobes. Major airway obstructions like a vascular ring or vessels. Then recurrent aspiration is one of the most common cause of recurrent pneumonias. Here what happens is recurrent aspiration can come because of severe GER or isolated or late presenting H-type fistulas or an esophageal dysmotility syndrome or some oily medication, nasal drop inhalations, laryngeal cleft, etc. And autoimmune disorders, pulmonary hemorrhagic syndromes, allergic bronchopulmonary aspergillosis, granulomatous disease, recurrent pulmonary, all these are a few causes. I will discuss in detail about these causes because sometimes this question can come as an essay note for the PGs, so that will help them out. Okay, so what are the pointers in history which we should ask? One is age of the child. If the child is tending to have a case of recurrent pneumonia right from very early childhood, it may be because of a childhood congenital anomaly or a hereditary disorders. We should also probe in detail about the cough nature, duration, and pattern. If you get a nocturnal or early morning cough, most common cause will be an asthma or a paroxysmal cough, foreign body. Cough related to feeds or swallowing can be related to gastroesophageal reflux or a swallowing dysfunction or a laryngeal cleft or a poor feeding technique. As simple as that. It can actually cause go on to have recurrent aspiration, and again child will tend to have a recurrent pneumonia. What about a croupy cough? That when you hear a croupy cough, please note that may be an involvement of the glottis or the epiglottis. Now, you also need to ask about the past history of recurrent skin infections or ear infections or recurrent diarrhea to rule out an immunological abnormalities. Premature delivery and the need of home oxygen suggest a diagnosis of bronchopulmonary dysplasia as a cause of recurrent pneumonia. Now, you have to see whether the child is growth retarded, because growth retardation is seen in case of tuberculosis, cystic fibrosis, etc. Family history of allergy, asthma, cystic fibrosis, immunological disorders, recurrent infections, all this have to be asked. Parental smoking, yes, we know because secondhand smoking, that's very dangerous too. We need to then find out whether it's a reactive airway or an asthma, and smoking can be a trigger for that. Presence of any pets has to be asked. We also need to ask about the immunization history because a well immunized child is protected against TB, pertussis, HIV, and streptococcus pneumonia. Please note here, BCG protects against extrapulmonary causes of tuberculosis or the dangerous forms of tuberculosis. Okay, pulmonary TB, very less protection from BCG. So, medication history, we should ask the patient whether the patient is on any long-term medications like immunosuppressants or any steroids. Because if the child is on immunosuppressants and all, we can think, okay, child is having some immunodeficiency or something like that. We should be able to clinch into a diagnosis. Now, what are the pointers in examination? So, we need to find out the weight, height, and head circumference and plot it. And to know whether there is any growth retardation, we need to find any dysmorphic features. If there is a digital clubbing, consider a chronic suppurative lung disease or a cyanotic heart disease, possibly with the left to right shunt. Any pallor is there because it can, iron deficiency anemia itself can be a cause of recurrent infections. Another thing is pulmonary hemosiderosis, pallor can be there. Central cyanosis. Then what are the things we are actually going to see in ENT? Examination of ENT, that is ear, nose, throat, is really important in any case of recurrent pneumonia. We need to see whether there are any polyps, which is seen in case of cystic fibrosis, any signs of rhinitis like presence of allergic sign, Silhouette, rhinitis, etc. All allergic rhinitis cases can have that. If there's a chronic rhinitis and hay fever, yes, used to suspect asthma. Is there any posterior nasal dribbling, which is seen in case of rhinosinusitis, and the presence of grommets or perforated eardrums, which suggests an underlying immunological problems or ciliary dyskinesias. Look for any signs of cardiac or systemic disease. Then chest examination, see for any previous deformities or scars from previous surgeries, presence of any V's, presence of lung crackles or persistence of lung crackles beyond 8 weeks. All this we should see. So what exactly are the investigations you will do in a case of recurrent pneumonia? So this image also I got it from the same article. The link is the reference is at the end of the session. So recurrent pneumonia we can divide as unilobar and multilobar. So the most common important investigation in any case of unilobar recurrent pneumonia is none other than flexible bronchoscopy. You do a flexible bronchoscopy, you see a foreign body, take it out. So if there is no foreign body, then if you do a bronchoalveolar lavage, you can actually do a biopsy if there is any neoplasm or any growth seed. But if all the things are normal, then you have to go and do a CT chest. Look for any space occupied lesions like a neoplasm or a sequestrated lobe, which is actually causing the problem. And we have already discussed in detail about sequestrations in the previous videos. Iotogram is one of the specific investigations in case of a sequestration. So what about this multilobar pneumonia? Here we need to first check the immunity of the child. What is the immunity? So you, for the immunity, check of the immunity, general investigation like total complete blood counts. You can actually see the immunoglobulin levels, IgA, IgE, IgG, all levels can be seen. You can see the response to the antigens like Streptococcus pneumoniae and T cells and B cell substance, all you should see, which I will discuss in the further slides. So in case of a recurrent pneumonia with immunodeficiency, we have to find out whether it is a congenital immunodeficiency or is it an acquired immunodeficiency. Suppose it is a case of the immunity is normal, then that means it's a case of recurrent pneumonia with a normal immunity. We have to rule out a cardiac failure. Any aspiration is one of the most common causes of recurrent pneumonia. As I have already mentioned, in case of GERD, do a esophageal pH monitoring. Okay, and if we are suspecting further things, all this video fluoroscopy can be done if you are suspecting esophageal dysmotility syndromes. So, if case of allergy or asthma, do a PEFR and other related investigations for that. Post-infective bronchiectasis is one of the common causes of recurrent pneumonia affecting multiple lobes, and post-infective bronchiectasis is very common, especially after infections like measles, tuberculosis, etc. Structural abnormalities should be ruled out, and mucociliary deficiencies also needs to be ruled out. So these are the investigations which I discussed: esophageal pH study, video fluoroscopy for oropharyngeal incoordination. You can actually go for technetium scan, esophagoscopy, and biopsy. The pH study is not conclusive. PEFR in case of asthma, immunity, a CBC with immunoglobulin profile, IgG subsets, antibody response to tetanus, Haemophilus influenzae, pneumococcal vaccine, all to detect any immunodeficiencies in the child and complement and T cell and B cell subsets. So, what will you do for the workup of the tuberculosis? Yes, we need to rule out a pulmonary TB. So, do a sputomicroscopy culture, G aspirate, manto. Nowadays, a manto we are actually not doing. We can actually consider doing the lavage and IAGRA for different TB assays and all. This we have to do and rule out tuberculosis. Cystic fibrosis sweat test and confirmation by genetic studies to look for cystic fibrosis transmembrane regulator mutations. Oxidative burst test known as NBT for chronic granulomatous disease. We have to also do a HIV serology, exhale nitric oxide for primary ciliary dyskinesias, etc. This certain investigation will not be available in primary or secondary tertiary care centers. It will be available. Like for example, this exhale nitric oxide test and all. Last, I just want to have a word about middle lobe syndrome. Middle lobe syndrome is one of the most common cause of focal recurrent pneumonias. The reason is middle lobe bronchus is relatively narrow and long, and that arises from the bronchus intermedius with an acute angle. That is one thing of reason for middle lobe syndrome, and the also thing is it can be compressed by large adjacent lymph nodes, and there is no collateral ventilation between the middle lobe and other lobes. And so what happens because of it? It actually decreases the likelihood of reinflation after the development of atelectasis. Because of these reasons, the middle lobe tend to have a recurrent pneumonia again and again. So middle lobe syndrome is one of the most common cause of focal recurrent pneumonia. I just put a slide because I thought like sometimes the PG aspirants or NEET aspirants may get a question from this or this, and moreover we need to know about this middle lobe syndrome as one of the most common cause of focal recurrent pneumonia. So in this session we have actually discussed about the definition of recurrent pneumonia, what exactly are the types, how will you approach in the history and examination, and also what are the investigations we will actually go through or to do in any case of recurrent pneumonias. This is my reference for this session. And thank you so much for your patient listening. Have a great day.